Good evening, everyone, and thank you so much for taking the time to join us for this important program about innovations in cardiac care. My name is Cindy Mers, and I'm the Vice President of the Suburban Hospital Foundation. In this role, I have the opportunity to partner not only with our incredible donors, but also with so many of our leading physicians and other experts who are continually working to improve patient care and to assure that the most advanced treatment options are always available for the members of our community. Generous contributions from so many donors, including many of you who have logged on to this webinar, have often made the difference between ordinary and extraordinary in these clinical programs. And for that, we are so grateful. Over the past year, the importance of healthcare has certainly been front and center across our globe and here at Suburban Hospital. And while most of the emphasis has been on the pandemic and most recently on vaccines and questions about vaccines, I can assure you that our other experts in the field of cardiac care have been busy fine-tuning new procedures and implementing innovative techniques. Tonight, we are going to hear from 4 truly outstanding physicians, Dr. Joseph Marine, Dr. Thomas Matthew, Dr. Eric Lieberman, and Dr. Greg Kumkumian, all of whose names and titles should be on your screen at this point. After they each present, we will also have an opportunity for live Q&A. And so we are very hopeful that you will take the time to put some questions in our Q&A section at the bottom of your screen. As I think it was already mentioned, this session will be recorded. So if you need to have an opportunity to see it or share it later, we will provide that to you. And at this time, I'm just going to be thrilled to turn it over to Dr. Joe Marine, and I hope that you'll all join me in welcoming him.
Thank you very much, Cindy. It's a great pleasure to be here. Thanks to all of you for joining and for all of your support for Suburban Hospital and Johns Hopkins Medicine. My name is Joe Marine. I'm a cardiologist and electrophysiologist at Johns Hopkins Hospital, and I also have the pleasure of serving as Section Chief of Cardiology for Johns Hopkins Community Physicians. Cindy, you want to bring up our first slide? So I'm just going to introduce our evening by talking a little bit about this great partnership that has been building over the past 20 years between Baltimore and Bethesda, Johns Hopkins Hospital and Johns Hopkins Medicine and Suburban. This goes back to the middle of the last decade, 2006, when Johns Hopkins and the NIH and Suburban Hospital came together to begin the NIH Heart Center at Suburban with the Cardiac Surgery Center. In 2010, Suburban Hospital joined the Johns Hopkins Medicine family. And in 2012, Maryland Heart, the largest cardiology group in Bethesda, joined Johns Hopkins through Johns Hopkins Community Physicians. So we've been all together now for 10 years. And we've been working very hard on converging our cultures, on building our two-way flow of knowledge and information and flow of patients for care across the continuum, across the Mid-Atlantic region, and collaborating importantly in many areas of research and education. Go to the next slide. We now have a cardiovascular network that spans the Mid-Atlantic region through 5 hospitals, 3 practice organizations, Johns Hopkins Community Physicians, Johns Hopkins Regional Physicians, and the faculty practice. We practice cardiovascular medicine now at 15 ambulatory sites, have nearly 100 cardiologists and 10 cardiac surgeons, all working together with our great anesthesia teams, radiologists, and staff, with the real goal of working as one team with one mission. Next slide. And that is the Johns Hopkins Medicine mission, vision, and values to improve the health of the community and the world by setting the standard of excellence in medical education, research, and clinical care. Next slide. We've been collaborating together on many fronts. On research, we did a MRI compatible pacemaker trial where Suburban was actually the largest enroller in the health system. We've also collaborated in research on safe MRI scanning of patients with pacemakers and ICDs. Johns Hopkins, in partnership with Suburban and Sibley Hospital, was the only center in the Washington, D.C. region able to do these specialized scans. We've collaborated on education with the Suburban Cardiovascular Symposium, an annual Mark F. Weinstein lecture that has been going on now for 9 years, and the Johns Hopkins Provider Retreat, in which the cardiologists are major contributors. We've been collaborating extensively on patient care, as you'll hear about, in cardiac surgery, in the structural heart program. We now all work on a single integrated medical record platform. We have clinical communities where cardiologists from Suburban and Johns Hopkins sit together on the same committees, meeting monthly on crafting the best care pathways for heart failure and for patients with arrhythmias, finding the best destination for care, whether it's in the Washington region or in Baltimore, to provide seamless care across our entire network. Next slide. This is just a patient example that comes to mind, a patient who is a 71-year-old retired truck mechanic who presented to Johns Hopkins Heart Care with shortness of breath, was found to have atrial fibrillation, a common cardiac arrhythmia, and a leaking mitral valve. At Suburban Hospital, he underwent a complex mitral valve repair and maze operation for his atrial fibrillation, did beautifully, but shortly thereafter presented with a different kind of arrhythmia, ventricular tachycardia. He required a defibrillator implant, also done at Suburban Hospital, but had more ventricular tachycardia and required a more complex procedure that is not done there. So he was transferred to Johns Hopkins Hospital, where he underwent mapping and ablation of his ventricular tachycardia that you can see up here in the red and on the slides to the right. That was successful, and he's been doing beautifully since then. So a great example of collaboration across the system through the continuum to get the patient the right care that they need at the right place and the right time. Next slide. So we at Johns Hopkins are very proud of this collaboration, and we're looking forward to hearing some of our outstanding physicians and surgeons at Suburban tonight talking about their innovative work in the fields of cardiac surgery and structural heart disease. So without further ado, it's now my pleasure to introduce our first speaker, Dr. Thomas Matthew, who is the director of the Johns Hopkins Cardiothoracic Surgery Program at Suburban Hospital, an assistant professor of surgery at Johns Hopkins. He earned his MD from Columbia University and did surgical training at the University of Virginia. He previously practiced in Louisville and Colorado, where he developed a thriving practice before being recruited to lead our cardiothoracic surgery program several years ago, and look forward to hearing his remarks. Thomas, please take it away.
Thank you very much. Thank you, Joe, for such a kind introduction. I also spent 15 years in Colorado after Louisville, Kentucky. So I want to give some credit to my team out there at the University of Colorado that really prepared me for this foray into academic medicine at Johns Hopkins. And thanks so much for the introduction, and thank you to the audience for your support of Suburban Hospital. We certainly couldn't do what we do without your help. I wonder if the slides can come up. Fantastic. I thought I'd give an update on what we're doing. This is a great time in cardiac surgery. We are in an incredible time of thriving at Suburban Hospital, largely due to the groundwork that was set before. I joined a program where there was already the elements necessary to work in collaboration with cardiology and cardiac surgery. In fact, at my interview, I talked with Greg Kumkumian about putting together a collaborative team to evaluate high-risk cases the way we did in Colorado. And that has been a big part of the success. Next slide. So we set several goals, and two of the big projects that we've done in the last 3 years since I started has been a project to reduce the mortality after coronary artery bypass surgery and to reduce blood utilization. And in each case over the last 3 years, we've been able to reduce those issues to below the national average that is established by the Society of Thoracic Surgery, the STS. Next slide. This is kind of a busy slide, but if you look over to the upper right, the operative mortality in 2017 was above the STS average, and over every year since I started here, we've built a collaborative effort that allowed us to reduce this to well below the national average. And if you look at the lower left, this is actually the observed to expected rate, which you would expect actually, you would expect that as the cases got harder, that the mortality would get worse. But in this case, the green line, the mortality risk went up as our mortality outcomes went down. So this shows we're doing tougher cases, but we're getting better results. And a lot of this has to do with the team approach. Next slide. What we did was we developed a protocol where we identified high-risk patients. And then we established a collaborative high-risk case review committee with the help of both Dr. Kumkumian and Dr. Lieberman and others. Dr. Bingham, the whole team was involved, as well as my partner, Dr. Fayez Hashmi. And we began to triage patients between surgery, high-risk angioplasty, medical treatment, or perhaps even transfer to Johns Hopkins in Baltimore if that was appropriate. We also did some standardization of handoff between anesthesia and the ICU. We improved our communication with the ICU, especially at night, and we standardized our daily rounding procedure. And that all led to a huge success in reducing mortality after our most common operation, coronary artery bypass grafting, CABG. At the same time, we wanted to reduce blood utilization. So we started yet another meeting where we reviewed our blood utilization in a monthly case review. And we discussed patients that were transfused and whether they were transfused at a level above or below the cutoff for transfusion with respect to hemoglobin. And there were very often reasons why, but then there were times when perhaps transfusion could have been avoided, and we discussed that, including enhancing communication before transfusion. Sometimes people were being transfused because one person thought it was a good idea, but when in consultation with the rest of the team, alternative methods were found to be available. We also started doing something called P2y12 testing, which is testing of drugs that cause a relative anticoagulation for therapeutic reasons before surgery, such as a person who might have had a stent or a person who might have had a stroke, and they're on a drug like Plavix. And if you stop those drugs early enough, then it can reduce the amount of blood use after. And the P2y12 testing gives us a numeric gauge to guide that therapy. Next slide. So this shows our blood utilization. The blue line is the intraoperative blood utilization, which you can see has come down and fallen below the national average by the Society of Thoracic Surgeons. Our blood utilization postoperatively is on the green line, and it's decreasing. We still haven't crossed that threshold yet, and we're still working to improve our communication and our techniques, and our committee is still working. And I hope next year to report that this is below the national average as well. Next slide. So our patients are older and sicker, but we're getting better results because we have enhanced communication between surgeons, cardiologists, intensivists, and anesthesia. Next slide. This translates into not only better outcomes, but reduced cost in terms of fewer readmissions, shorter ICU stays, and fewer returns to the OR. And of course, reducing blood transfusion that directly reduces cost the cost of the blood and the equipment required to transfuse the blood, as well as other deleterious effects of blood transfusion. Next slide. I just thought I'd show on a side, in addition to CABG mortality reduction, we've seen a steady reduction in the mortality after aortic valve replacement. In fact, we've hardly had any death at all after surgical aortic valve replacement, and that includes the minimally invasive valve techniques that we have used. In fact, some of those have been really sick. My partner, Dr. Hashmi, his first minimally invasive mitral valve was in a patient on hemodialysis who had previous strokes. I thought he was kind of crazy for doing it that way, especially his first case. But he had so much experience and so much confidence. And when we actually did it that way, and I saw that a 70-year-old patient without the trauma of a sternotomy actually recovered faster. So next slide. This just shows the scoring method of the Society of Thoracic Surgeons for coronary bypass grafting. I just put this up there because the rating is 1-star, 2-star, 3-star, which is so insensitive to really show what's going on. It shows that we're a 2-star program in everything and 3-star in medications. 1-star is really bad. You don't want to be that. And most programs are 2-star. But if you look actually at the scoring, you'll see that we are overall and in almost every category better than the national average of the STS. And in fact, we approach the 90th percentile in some of these scores. So if you look at the real details, you can see actually our program is doing better than many of the programs in the country, even though it's really hard with the numbers to get to the level of 3-star. It just takes volume to do that. But the good news is our volume's increasing. So I hope to report that we can get up even higher in some of these other areas. For example, we do internal mammary arteries on almost 100% of the cases. We're still 2-star just because of the volume. Next slide. So we've reduced the mortality, we reduced blood usage, which was our goal. We're still in process, and I expect us to get better. But I have another thing that I'd like to talk about, which I'm very excited about. Next slide. This is the minimally invasive valve surgery program. And you're about to hear about transcatheter valves, which are an excellent addition and have brought more and more patients to the hospital. But then what do you do with those patients that have to have a surgical valve? They came for a very minimally invasive procedure, and now they're told they're going to have their chest cracked because they're not a candidate for TAVR, or they're too young for a TAVR, or there's some other anatomic reason they can't have a transcatheter valve. Well, we want to be able to show them that they can have a less invasive approach to a mitral valve replacement, an aortic valve replacement. Even an atrioceptal defect can be done this way without sternotomy. Next slide. This shows the standard sternotomy. It's a big metabolic hit, especially for an older patient. Of course, patients recover and they do well. We've been doing it for years. Next slide. But it's better to use a smaller approach where we use a 3-inch incision in the anterior chest wall. We connect to the heart-lung machine through the groin, and we're able to replace the mitral valve or the aortic valve through a small incision. Next slide. We go through the 4th interspace for the mitral valves and through the 2nd interspace for the aortic valves. Next slide. This is what a sternotomy looks like postoperatively. Again, the patients do well, but it just takes a while. It can take 6 to 8 weeks, sometimes even longer, for patients to recover from the sternotomy. Next slide. This is the incision for a mitral valve replacement. It's only about 3 inches long, a couple chest tube incisions there. and there is no sternotomy. This patient at 2 weeks is back driving again, involved in cardiac rehab, and with much less pain and metabolic disarray from the large sternotomy. Next slide. So what's needed? We've got a great program. We've done over a dozen of these here at Suburban Hospital. In fact, I think we've done 15 total, and we have several on the schedule. I suspect that we're probably going to approach 40 or 50 of these a year, and maybe more depending on how the entire valve program grows. But in order to do that many cases, we need more than one set of instruments. And right now, we have one very old set of instruments that we're using that we inherited from the previous program. They're very expensive because they're very specialized shafted instruments that allow you to work with your fingertips at the end and control something that is 12 to 18 inches away down in the incision. So this might be something that would be an opportunity for the foundation to help the hospital with obtaining one or two more of these sets so that we can do 2 cases in a day, perhaps, because we're not allowed to flash things anymore, or so that we might one day be able to do 2 simultaneously. And also to have a backup set in case an instrument gets contaminated or broken. It just makes sense to have more than one set of instruments. Next slide. Next slide. Yeah, thank you. Okay, good. The last one was questions. So thanks again for the opportunity to present. I don't know if we'll take questions at the end. That might make more sense. We can go into the next presentations. Thank you so much for the opportunity to present.
Thank you, Dr. Matthew. And again, we will take questions at the end. So please start to think about your questions and enter them in the Q&A window. Dr. Matthew, that is extremely impressive work. Clinical quality, excellence, and innovation is at the center of what we do at Hopkins Medicine, and the work that your team has done in such a short period of time really exemplifies that. So thank you. We're going to turn now to interventional cardiology, and I'll introduce Dr. Eric Lieberman. He is an interventional cardiologist with Johns Hopkins Community Physicians Heart Care and Suburban Hospital, where he previously served as chief of the Division of Cardiology. He earned his MD from Emory, trained in internal medicine at Johns Hopkins and cardiology at Duke University. After completing his fellowship, Dr. Lieberman served as major in the United States Air Force and was attending cardiologist for the Naval Medical Center in San Diego and director of cardiology research at the clinic. He also earned his United States Navy Commendation Medal during that period of time. Since coming to Washington, Dr. Lieberman has repeatedly been named a top doctor in Washingtonian magazine, and we were fortunate enough to recruit him to Johns Hopkins 7 or 8 years ago, and he's going to talk to us about the innovative TAVR program that he's been leading. Dr. Lieberman.
Thank you, Joe. I'm just going to share my screen. Can you see my screen? No. Okay. Hold on one second.
We're seeing structural heart program. Perfect.
Perfect. Okay. Thank you very much for the introduction. So I'm going to be speaking about a structural heart program. And what do we mean by that? A structural heart program focuses on innovative, primarily catheter-based treatments for complex structural heart disease. And these issues of structural heart disease really pertain to the walls of the heart and the valves inside the heart. Some of the procedures that are done in a structural heart program include replacing an aortic valve, not by open heart surgery, but by using a catheter. And that's a TAVR program. Also, and I'll be speaking on that. Dr. Kumkumian will be speaking about transcatheter mitral valve repair, left atrial appendage closure, and some additional procedures to close holes in people's hearts. I would be remiss if I didn't mention that our new tower, which was supported by the foundation and by the community, really enhances our ability to offer cutting-edge structural heart disease procedures. Traditionally, a cardiac catheterization lab looks like a radiology suite, and it's in a location in the hospital distant from an operating room. This is a photograph of our structural heart disease lab, which is really an operating room that has cath lab equipment in it. So you can see a large, what we call C-arm. It looks like a robot, and that's actually the X-ray camera that can get angulated views and swivel into different positions to allow a full operating room team to be present during cath lab or catheter-based procedures. And it opens up the opportunity to do hybrid procedures that include perhaps a whole operating room team and a whole cardiology team. And this spacious cutting edge lab is obviously very expensive and very new. And we're very fortunate to have this facility at Suburban Hospital. If we look at open heart surgery, as Dr. Matthew outlined, it involves a sternotomy, whereas transcatheter aortic valve replacement does not involve a sternotomy. The approach to the patient is through a puncture in an artery. So there's no sternotomy. And in the case of a transcatheter aortic valve replacement, or TAVR, people are not placed on a heart-lung machine. We're working on the engine while it's still running. And patients are spared general anesthesia. The procedure can be done with deep sedation. And so patients avoid some of the potential side effects of general anesthesia and being placed on a heart-lung machine. Of course, if a patient is not getting a sternotomy, the recovery is much quicker, and you avoid the potential complications associated with the large wound. So at Suburban Hospital, in our TAVR program, the average patient age is 87 years of age, and the hospital stay is 1 day. So think about that, an 87-year-old going home with a new heart valve the day after the procedure. For the TAVR procedure, 98% of the time, a catheter is inserted into one of the femoral arteries, which is located in the groin, and the catheter is threaded up from that artery to get to the heart. And we position the catheter, the plastic tube, onto which the catheter-based valve is mounted. We position the TAVR valve in location and then open the valve up. For the remaining 2% of patients who, for one reason or another, can't have the valve positioned from a femoral approach, there are other potential opportunities, including using arteries in the upper chest, or even in the or even approaching through the chest wall directly. Currently, in the United States, there are 2 commercially available TAVR valves. The one on the left is made by a company called Edwards, and it's called the Sapien valve. And the one on the right is made by a company called Medtronic, and the brand name is called an Evolute valve. And they each have different features that are beyond the scope of our conversation. Just to summarize it, The Edwards valve on the left is mounted on the catheter, and we call it a balloon expandable valve, where we inflate a balloon and it opens up the valve, and then the valve is pressed into position. It's not held in with any stitches. On the right, the Medtronic Evolute valve has a metal frame that's made of nitinol, which is a self-expanding metal frame into which tissue is hand sewn to create the valve flaps itself. And so for the Evolute valve, it is constrained by a tube covering, and we slowly withdraw that tube and the valve flowers open into place. And each of these valves has particular advantage for certain anatomy. And here at Suburban, we use both valves. We have all the valves that are available for use. And to give a better illustration of what I'm talking about, this series of photos from one of our patients shows a Medtronic Evolute valve being deployed. And so just by way of orientation, on the left, you see a wire that goes from the aorta, the main blood vessel in the body, down into the left ventricle, which is the pumping chamber in the body. And this black line is kind of the constraint. You can think of it as the constraining tube that covers the valve. And we've withdrawn that tube to let the valve flower open. And so you see at the bottom of the valve begins to open, and we are injecting X-ray dye in panel number 2 to show the position within the aorta. And by panel number 3, you see the valve fully open. And then on the far right, you see a picture that faintly shows the outline of the aorta and the aortic valve flaps. And that process is slow and deliberate to ensure that we have the valve positioned exactly where we would want it. And this is a screen grab that just shows us working. And you can see the valve is partially opened on the heart side, and we're gradually opening up the, pulling back the covering tube to allow the valve to open up. And so we then go to the next picture, which now shows the valve is fully open and in the correct position. And this, we inject some X-ray dye just to confirm the position. So that is what we call the self-expanding Evolute valve. So this is not on fast forward. This is true speed. This is the deployment of the balloon expandable Edwards valve. And you can see it's mounted on a catheter, and we pace the patient's heart rate super fast, so to minimize the movement of the valve as we are positioning it. And then the valve opens up in the correct position. So this is much more rapid and might be of choice in people where you need to deploy the valve more rapidly. Incidentally noted, this is the patient happened to have a pacemaker in at the top right of that screen. And on the right panel, you see what the Edwards Sapien valve looks like once it's fully deployed and in position. So now that we've seen what it looks like, how do you compare TAVR or catheter-based valve replacement with what we now call SAVR or surgical valve replacement? And there have been a series of studies since 2011 that compare TAVR versus SAVR, first in patients deemed at very high risk for surgery. And so you might choose TAVR for them. Then once TAVR was shown to be superior for high risk patients, Studies move down the risk spectrum to intermediate risk patients and low risk patients. And when you compare TAVR to SAVR, TAVR, catheter-based valves, is associated with a lower operative mortality rate in patients who have an intermediate or high risk of problems with surgical valve replacement. TAVR was better. And in fact, when you broaden it to all safety measures, TAVR outperforms open heart surgery when you're talking about safety measures. When we measure how well the valve works, when we look at pressure differences across the valve, that with TAVR, the valve just seems to work better than surgically implanted tissue valves. The one thing to consider with transcatheter aortic valve replacement is that there is a higher rate of patients needing a pacemaker as a result of the TAVR. And that's because when we press the TAVR valve into place, we can interfere with the conduction of electricity through the heart valve, through the heart, because the electrical system runs right next to the aortic valve. The national rate of needing a pacemaker following transcatheter aortic valve replacement is 10 to 15%. But at Suburban, with modifications of the technique, our rate is down to 5%. So we're outperforming the country as a whole. So now I'm going to stop screen sharing, and I'm going to open up to Dr. Kumkumian.
Thanks, Eric. My name is Greg Kumkumian. I'm on the structural heart team. I'm an interventional cardiologist. And I want to continue on from Eric's discussion, Dr. Lieberman's discussion about TAVR, and talk about a few other areas where structural heart treatment of heart disease has really started to take off and really is important in terms of care of patients. The three areas I'll touch on are closing of patent foramen or valley or atrioceptal defects, small holes between the small chambers of the upper chambers of the heart. Left atrial appendage closure, typically in the United States, performed from the Watchman device, using the Watchman device. Mitral clip, using a mitral clip to minimally invasively improve a leaky mitral valve. And I also just want to very briefly also talk about our use of the Impella device, which is a left ventricular assist device to help the heart pump in patients who've had a cardiac arrest, who are in cardiogenic shock and congestive heart failure, or to perform high-risk interventional, minimally invasive stenting procedures. And I think, I really want to highlight this is because of donors to Suburban Hospital, we were able to kick off our program with this Impella, which is the device we use to assist us in these sicker patients who have a weakened heart muscle or who need high-risk procedures to be performed minimally invasively. Just briefly to remind you, a PFO or ASD, patent foramen ovale on the left panel and atrioceptal defect on the right panel. These are small holes in the upper small chambers of the heart between the left and right atria. The patent foramen ovale is an incomplete sealing of the opening that is a remnant from birth. In utero, the fetus, the baby, has that hole so oxygenation can be passed from the mother to the baby, and it seals within the first few years of life almost completely, except for in about 25% of individuals are left with a very small remnant. That generally does not offer or does not cause any significant risk to individuals, except for in the situation I'll mention to you in a moment. The atrioceptal defect, which is on the right panel, is slightly different. It's a malformation, I think is the right way to describe it, and typically a larger hole between these two small chambers, which causes a significant increase in blood flow. I should say it allows for a significant flow between the two sides of the heart, which are usually sealed off from each other. And that over time can cause the right side of the heart to become enlarged and weakened and increase the risk of arrhythmias, among other things. So I want to start first talking about the procedures that we are performing at Suburban Hospital, started performing in 2019 in conjunction with our structural heart program. Again, that is a collaboration with Johns Hopkins Hospital structural heart program. We're really one program working together to do better for our patients. So the ASD or PFO closure procedure is performed, as Dr. Lieberman was talking, from the groin, from the vein, however, instead of the artery going up the right side of the heart, and very carefully closing up the hole that's left, either as an atrioceptal defect, which is a malformation, so that that small hole not only didn't close, but didn't form correctly between the two small chambers, or in the case of a patent foramen ovale, a small remnant hole left. This allows us to perform this procedure minimally invasively, going from the femoral vein, the vein in the groin, up to the heart. And in the rightmost panel, you can see a small closure device is placed. It's called an occluder device. I wanted to give you an example. These are snapshots from a patient we performed this procedure on recently. And it's an interesting case, a 49-year-old principal of a local school who very healthy otherwise, no risk factors for heart disease, no family history, who suffered a stroke, recovered fully from the stroke, had a complete evaluation and found no cause for that stroke, except for a patent foramen ovale, this very small remnant hole that for the vast majority of people never causes a problem or needs to be treated. But in the case of individuals young, like this patient of ours, who've had a stroke and no cause can be identified, they're defined as having a cryptogenic stroke, a stroke that no cause can be identified except for this small remnant hole, this PFO. So recent trials have identified that these patients actually do a little bit better if that hole is closed when compared to standard treatment, which is antiplatelet medication such as aspirin. And this is performed again from the femoral vein, moving our catheters up, that's the leftmost column, and then deploying the device, that's the beginning of the deployment in the middle column. And then on the rightmost column, you can see that deployment, and I'll go back a picture to show you the rightmost column in the image, it shows it, and here it shows it in an actual patient. And that closes up that small hole, reducing the risk of future stroke. This patient did quite well, left the hospital the next morning, and we're going out on about a year later, doing very well, living an active life. Our program for the PFO and atrioceptal defect closure program started about a year and a half to 2 years ago, our outcomes have been excellent. And again, this shows again excellent collaboration between the two centers in Baltimore and in Bethesda, and the unique opportunity to do good work for our community. The next thing I'd like to talk about that falls in the structural heart community that is performed by interventional cardiologists and electrophysiologists is a left atrial appendage closure procedure. The one most commonly used in the United States is called the Watchman device. And it's a expanding nitinol cage, which has a membrane around it. And individuals who are candidates for this procedure are those who have a history of atrial fibrillation, an abnormal rhythm that has an increased risk for stroke. And the stroke most frequently occurs from a clot forming in the small pocket called the left atrial appendage, which I'll show you. And individuals who are too high risk to be on blood thinners, but are at high risk for stroke, if not on blood thinners, are a candidate for this procedure. Going from left to right, again, just demonstrating this is done minimally invasively from the groin, the vein. And in this case, if you look at the panel going left to right, in the second panel, we are actually creating a hole across that septum, that atrial septum that we were just repairing in the other procedure, going across to the pocket which you can see in your third panel, and putting the device across that, into that panel, into that appendage, excuse me, closing up the hole. And it was found that individuals who were a good candidate for this procedure did comparatively well to those who were on anticoagulation with warfarin or Coumadin, which for the longest time was the most commonly used anticoagulant. Next, just to move along, the mitral clip device, which is, this procedure is being performed in Baltimore, not yet in Bethesda at Suburban Hospital. This is a minimally invasive procedure, again, from the groin, moving a clip up across the heart from the right to the left side and clipping a leaky valve so that the cusps of the leaflets of the valve are brought back together so the degree of leakiness is, improves. Patients who are candidate for this are patients with typically chronic, moderate to severely leaky mitral regurgitation or leaky valve, who have heart failure and who have favorable anatomy. Those who have heavy calcification of the valve may not be good candidates, and who have a prohibitive risk for surgery, who are at high risk for surgical repair of the valve. This has been found to be an excellent approach, minimally invasive. And then lastly, I just want to touch quickly on the Impella device. It's a left ventricular assist device that we use at Suburban Hospital for patients who've had a cardiac arrest or cardiogenic shock, patients who need a high-risk coronary stent procedure, those who are too high risk for surgery. And this device is again put in from the groin, the femoral artery, and it looks exactly as you see it. It's a small device that goes into the ventricle that helps the heart pump up to, in this case, about 4 liters per minute, providing support to the heart when it is weakened, when a patient is in distress, or when a high-risk coronary stent procedure has to be completed. And this is kind of the mechanics of it. It's a very small engine. One end of this is in the ventricle, the other end in the aorta, and this pump generates and moves blood through it, creating significant cardiac output to support a patient's cardiac output of their own ventricle, which typically is weakened in the patients we put this in. And again, I want to highlight this because this device only came available to us after a generous donor gave to help us purchase this device and to start the program. And that was just a few years ago, about 4 or 5 years ago. Lastly, I just want to kind of review again the importance to consider the fact that Suburban Hospital, Bethesda, has benefited from a collaboration with Johns Hopkins Hospital in Baltimore, bringing 2 really good teams together to do excellent work, helping both communities do good research, to care for sick and ill patients, and to offer opportunities that otherwise wouldn't be available. On the left column are the physicians that are leaders in Baltimore. On the right at Suburban, and Dr. Hassan, we are fortunate, travels both between Baltimore and at Suburban to help lead our program. And then lastly, I just want to finish, just want to remind, everyone that everything we do takes a team, and this is just a small sample of all the people who work really hard to bring this program. The structural heart program just has passed 4 years, about 150 TAVRs, and really does a great job in working hard to take care of our patients. And I want to thank the team as a whole who do a good job to help us. And so with that, I want to thank everybody for their attention and for joining us.
Thank you so much, Dr. Kumkumian. And you and Dr. Lieberman have really shown how quality care is a team effort. Working with our colleagues in Baltimore, you introduced these innovative procedures to Suburban Hospital, and we thank you for sharing your work with our audience. We now have time for a few questions which have come in. Our first question is from an audience member who had a human replacement aortic valve done in Fairfax. Will minimally invasive surgery become the norm? Is it only done with bovine or mechanical valves? And you might particularly speak to if a replacement valve were needed for him?
Absolutely. Well, that's an excellent question. And yes, you can put any type of valve in place. We have not used a homograph. We typically use those in cases where there's infection involved. It would be possible to place a homograph through a minimally invasive. If that kind of case came up, we would address it. I put a mechanical valve in yesterday, and we put 2 tissue valves in the week before. So yes, minimally invasive will be an option, but we're still going to need to do sternotomies for those patients who need an aortic valve and a coronary bypass or some other procedure. But yes, it would be very possible to do a homograph through a minimally invasive approach.
Now, can TAVR be performed in a homograph? Have you done it? Is there any reports of TAVR in homograph? We certainly have cases of TAVR in replacement aortic valve, if it's a bioprosthetic valve, if that were to be needed.
I would just reiterate that we have done quite a few of TAVR valves in previously replaced valves, not mechanical valves, of course, only tissue valves. So that's not possible in a mechanical valve. I don't know if Dr. Matthew or Dr. Lieberman want to add to that.
Theoretically, you could put a valve inside a homograph. I don't see why that wouldn't. But sometimes they calcify, and that can be good. Other times it might create a challenge. So that kind of case, we might send to Johns Hopkins, Baltimore, where they have more experience. They probably have put some valves inside a homograph. If I ask Ronnie or one of the others, they might be able to give us more experience on that.
Great. Should everyone who needs aortic valve replacement have the TAVR procedure? Should anyone undergo valve surgery anymore? A provocative question. Their interventional cardiologists are working on it, but I don't think we're quite there yet. Guys?
So we've moved in the TAVR world from considering the surgical risk with surgical aortic valve replacement to now considering the longevity of the patient. The TAVR was FDA approved in 2011, and it is known that cow or pig valves that are implanted surgically have a lifespan of 10 years or a little longer. TAVR has not been around in large numbers for 10 years, so we don't know how long a TAVR valve will last, but we suspect it will be equivalent to a surgically implanted bioprosthetic or cow or pig valve. So if you have a young patient, you might not choose a TAVR because you'd be looking at repeated TAVRs over time. Also, if there's another reason for a patient to have open heart surgery, let's say coronary artery bypass surgery, then they really should have the valve surgically replaced at the time of bypass surgery.
And I would just add that at a recent meeting, I think Dr. Rizar was talking about this in Baltimore, they have not yet had any of the TAVR valves come back requiring another intervention or surgery. And that's just anecdotal, but it's a good sign.
That's a very good sign. I've not had to replace any of my own surgically 26 years either.
Not a competition.
It is a virtuous competition for the longest, most durable valves.
Competition is good because it makes for a better outcome for the patients. And plus, I'm speaking out of both sides because I'm involved in the TAVR process.
That's right.
So I'm very pleased to see the number of aortic valves done in the state of Maryland is approaching 900 per year because of the TAVR program. In the biggest year, I think 2012, 500 aortic valves were done surgically in the state of Maryland. I'm the chairman of the Maryland Cardiac Surgery Quality Initiative, and we study these things. And it's doubled the number of opportunities to help patients. Mm-hmm. I'm a real advocate for TAVR. But if you're young and you need a single valve, I think you should have a mini approach and not have to have a sternotomy.
Another question, since Suburban is a trauma center, is emergency cardiac care always available 24/7?
Just ask my wife. The answer is yes. I think I sewed up 2 stab wounds with Dr. Westerban last month and a gunshot wound to the heart. You have to be really lucky to have the cardiac surgeon just finishing his case when you get shot in the heart. And Dr. Westerban said, "Where are you?" I said, "I'm right next door." He said, "Good, come here, I need you." So
that is a bit of good luck.
that was good luck. So having said that, yes, we have 24/7 availability. We do aortic dissections as well. And if cases come that look like with collaborative approach, they should be done in Baltimore, we have an easy transfer process to Baltimore, and we share a medical record. So they can see everything that we have here. It's seamless.
Yeah, and in terms of heart attack care, there's a team available 24 hours a day, 7 days a week. And we perform somewhere upwards of 80 to 90 emergency angioplasties a year.
That's such an important component of heart care. And there's a study after study has shown that opening up an acutely closed heart artery with angioplasty is the best way to treat an acute heart attack. And Suburban has been a leader in that for over 10 years. So very important that people can always get care at Suburban. How is Suburban and Hopkins addressing equity in cardiac care? That's a great question. You might maybe talk about a little about the mobile med program that you've done. That's really impressive work that you and your colleagues have done.
Well, every Thursday, our office, our cardiothoracic surgery office, turns into a clinic for patients run by Mobile Med, which sees patients who don't have the traditional ways to pay. And I've been very impressed with the level of care. They include people from the NIH, as well as some of our own cardiologists and internists who are involved with delivering state-of-the-art care to patients who have no way to pay.
That includes testing as well, echoes, stress tests, cardiac MRI, all completed without a concern about payment.
And of course, Suburban takes care of emergency cardiac care patients without any regard to insurance or ability to pay 24/7. They're all part of that.
Absolutely.
A topical question, have you seen more critical cardiac care needs as a result of COVID?
I would say that we have noticed a significant recent increase in acuity of care over the past few months. And we attribute some of that to patients getting their vaccines and finally coming in for care. I think Dr. Lieberman can talk about this too. We've seen quite a few heart attacks in the past month in particular.
I think that our experience at Suburban is similar to the national experience, where the cath lab volume fell over the past year, but if you examine death certificate data, the number of people who die at home has gone up. And I think I know in the case of some of my patients, people were reluctant to come to the hospital to seek appropriate care out of fear that they'd get exposed to COVID. And I think that was unfortunate. Right now, I think we're seeing a catch-up phase where I feel like we're extra busy and seeing more patients who are more ill than usual. Not necessarily directly due to COVID, but due to delays in seeking medical attention.
Yeah, and I think that delay has been seen nationally, and it's an unfortunate side effect of the pandemic. It's worth emphasizing with the protocols and safety that we use at Johns Hopkins. We've seen virtually no transmission that we can detect from to patients in the course of medical care. We really have an extraordinarily safe environment and have had dating right back to the beginning of the pandemic. So it's always been safe, but some patients have not felt comfortable coming back, and now we are seeing some of the effects of that. If someone has a cardiac care issue that cannot be treated at Suburban, would he or she go to Hopkins in Baltimore? Maybe you can describe that process.
Well, that would be the easiest place for them to go. because we share the same medical record and we regularly collaborate with team members. In fact, there is a webinar on May 5th where Dr. Kilich and I are going to talk about the collaboration between the two surgical programs.
Mhm.
And, I imagine from a cardiology standpoint, well, Dr. Hassan comes down, and Greg and Eric, do you see a pretty seamless collaboration with your colleagues in Baltimore?
Yeah, I mean, you know, every Monday we have a collaborative structural heart review of cases. There's a lot of collaboration back and forth on the cardiology and interventional cardiology side. Absolutely.
I think certainly on the electrophysiology side, I presented a case in my few slides of a patient who had a lot of care at Suburban, got fantastic care, but there was a complex ablation procedure that we only do in Baltimore. And so he was just transferred right up for that seamlessly. And you can, look at other examples. So our dedication is to the patient and getting the care that they need wherever it is. And we have the means someplace within the Hopkins system always. Transplant is another example. Heart transplants, LVADs are done in Baltimore when they're needed.
Dr. Marie,
yes.
I'm going to pop in for just a second, just to be respectful of people's time. We did say that we would end right around 6. We have these incredible physicians here answering your questions, and I know they're willing to stay on a couple minutes longer just to finish the list of questions that came up in our Q&A box. But for those of you who do need to drop off at this point, just wanted to really just thank you so much for taking the time to spend here with our experts to learn a bit more about our program and for all that you've done to support this program over the years. So I'm going to allow Dr. Marine to just finish with the last couple of questions and then really just take the opportunity to thank these incredible physicians and surgeons for giving us this time and giving this time to our community. So thank you so much, Dr. Marine. Feel free to continue with these questions for as long as people are able to stay on.
Sure. So what are the surgical and interventional options offered for hypertrophic cardiomyopathy, and where would they be performed?
So, so we care for in the Hopkins Heart Care in the DC area for many patients with hypertrophic cardiomyopathy. And we do that in large part in collaboration with experts at Johns Hopkins Hospital. And often how that collaboration works is that we care for the patients primarily, and we refer them for expertise in any treatments that they may need beyond medications. And the communication back and forth is excellent. And again, as Thomas has said, we share medical records, and many of us know each other fairly well and communicate well.
Johns Hopkins is recognized as a center of excellence. It's a designation, a center of excellence for the care of hypertrophic cardiomyopathy. And so we are fortunate to have that available to us, and particularly since we share medical records and they're just a phone call away. So while some of the heart rhythm disturbances around hypertrophic cardiomyopathy can be cared for at Suburban Hospital, some of the complex surgical options and just the difficult case management is referred up to Hopkins.
Because if the ventricle fails, you might need a left ventricular assist device, or you might even need a heart mate or a transplant. And all that is available in Baltimore. But yet we're able to evaluate those patients here and then seamlessly get them up to Baltimore as needed.
I'll take the next one. Has Johns Hopkins and Suburban developed new innovative treatments for congestive heart failure involving atrial fibrillation and atrial flutter? Absolutely. Catheter ablation has now become a mainstay of therapy for those arrhythmias, and they are performed at both centers, depending on the complexity of the procedure and what else is involved. But definitely catheter ablation is an important mode of treatment. The next question is this type of surgery that you've described used to repair a leaky valve, a leaky aortic valve? How is that handled?
So if the surgery you're referring to is TAVR, transcatheter aortic valve replacement, If it is a person's own original God-given valve and it's primarily leaking, TAVR cannot be performed because when the valve is blocked, the valve has a lot of calcium in it, and we use that calcium to anchor the TAVR valve. I had mentioned it's not sewn in. So you need to have significant calcium in the valve to hold the TAVR valve in. Now, if someone has a previously implanted surgical valve, the tissue, like a cow or pig valve that had been implanted by a surgeon, it's been in 15 years and now that's leaking, then it is often possible to do a TAVR inside a surgically implanted valve because that surgically implanted valve has a metal ring that would serve to hold a TAVR valve in.
But if the patient is with a native valve, their own God-given, as Dr. Lieberman says, valve, and they can't have a TAVR, that would be the perfect patient for a minimally invasive valve because you don't even have to do the debridement of the calcium. Mm-hmm. Open the aorta, cut out the leaflets, put in sutures, and drop a new valve down in there. So that would be a very good mini aortic valve replacement.
You do make that sound so incredibly easy, Dr. Matthew.
We'll take our last question from an audience member with a bad mitral valve and has been told no surgery should be done until it gets worse. Are there programs that should or could be done now?
I'll just start off just because I mentioned the mitral valve clip. If the valve, it depends on what's wrong with the valve. I mean, is the valve narrow? Is it leaky? If it's leaky, how much is it leaking? Is it leading to congestive heart failure? And so all that would help determine whether a patient is a candidate for a valve replacement, a valve repair, or a minimally invasive mitral clip. So one would have to work through what is the best procedure or process.
Great. And well, I will just, before turning it over to Cindy, thank you again to our speakers, Dr. Matthew, Dr. Lieberman, Dr. Kumkumian, for your talks tonight and for your innovative work. Thank you to our audience for your great questions and for your attendance tonight. You are our most loyal supporters of Suburban Hospital and Johns Hopkins Medicine. Your generosity makes so much of the innovation possible that you heard about tonight. And speaking for all the clinicians, we're very appreciative. Cindy, I'll turn it over to you to wrap up.
Thank you so much, Dr. Marine, and thank you for your outstanding leadership of this particular webinar. I know that a number of years ago, we had the opportunity, all of us together on this screen, actually had the opportunity to do a session like this in person with a couple of hundred members of our community in attendance. And I know how much everyone enjoyed the opportunity to meet all of you in person and have so many questions answered. Under the current circumstances, I'm so thrilled that we were able to pull together this webinar and still provide this incredibly important educational information to the members of our community and to the donors who have supported us for so long. So I do hope that we're all together in a room again sometime soon. But in the meantime, I'm just so grateful for everyone for taking the time to be here tonight. And I'm so thankful to all of the physicians and surgeons who took their time tonight. So this is the beginning of a series for us. This is a clinical care innovations series. So we will be actually tackling a few additional subjects as we move forward over the course of the next several months. We will have a survey going out to all the participants tomorrow. And we do hope that you'll give us your feedback and give us some ideas for things that you'd like to learn a bit more about. So we are incredibly grateful for your time. And with that, I hope that everyone has a wonderful evening.